Good morning, good afternoon, and good evening to everyone who are joining us on this webinar. Simply put, vaccines work. Vaccines save lives. Through their saving lives, vaccines have a profound impact on the society, on the economy, on the polity. There's no question that vaccines are one of the greatest public health interventions and success stories. So good morning and good evening and afternoon for joining us. My name is Vish Viswanath. I am a professor here at Harvard T.H. Chan School of Public Health and the Dana-Farber Cancer Institute. More germane, I'm also the faculty director for the Harvard Chan's India Research Center. As a part of the mission of the Harvard Chan's India Research Center, we have three goals. One is to advance research collaborations between students and faculty in India and Harvard Chan here at Harvard University, to promote capacity building. And three, which is the reason we are here, translation and communications, translating the evidence base to see how it influences policy and practice. And nothing could be more central, or no topic could be more central than vaccines. And that's the reason we are here today. Vaccination in India is a success story. As I said, it's not only one of the most public health interventions. I don't have to give you statistics. I think we have Ms. Gupta here from Gavi, who is better versed with about these things than I am, and other distinguished panelists. But the fact of the matter is that India alone, or in low and middle income countries, vaccines have saved almost 4 crore deaths in the last 2 years, in 20 years. And for every penny or every rupee that is invested in vaccination and immunization, the return on investment is close to 52 rupees. So, and in this success stories, India stands out. In many ways, there are many reasons why India stands out. One of them, of course, is the manufacturing in India. It is one of the largest, if not the largest, supplier of vaccines globally. And that is a story for another day, not today. You will hear from the panelists. India also has an amazing infrastructure. And of course, it's an editorial comment, but it's based on facts. Amazing infrastructure that pushes vaccines and vaccination to the ground level, even to the last mile. But third, there are a number of factors which led to its success, and those are the factors we want to explore. Why were we successful? But this is just not about celebration. Obviously, between COVID-19 and global anti-vaccine movements, vaccination and immunization is always under threat. And we want to know what the challenges are. In fact, Gavi has made a pledge and a promise and a mission to reduce the number of children without any vaccination, 0 doses as they call it, and we will hear about it shortly. So there are challenges, and the question is, what can we learn from what we have done so well, and what can we learn from what we have not done so well? And that's, we have highly distinguished panelists, people who have been central to the success of vaccination story in India and globally, and that's what we want to do. So with us on the panel today are Ms. Anuradha Gupta, who is the Deputy Chief Executive Officer at Gavi, the Vaccine Alliance. She's known to many people in India, even though her role right now is global. She's a former IAS officer. She's a passionate and influential advocate of women, children, and adolescents. She has led efforts to put equity, and this is very important, and equity and gender and communities at the center of Gavi's program planning. And she is the one who has pioneered the concept of zero-dose children, those who remain deprived of even a single vaccine shot. And she has led a number of efforts to create a new model of country-level alliance to support immunization and vaccination. So we are grateful that she was able to join us, and thank you, Ms. Gupta, for joining us today. Next, we have, shortly, we will have Dr. Ashok Babu, Joint Secretary of the Ministry of Health and Family Welfare, Government of India. When we are having some technical issues, when he's able to join us, I will introduce him, but he's a lead on reproductive, maternal, newborn, child, and adolescent health in India. Is a medical graduate and a Fulbright scholar, and with a master's in public health. Following that is Ms. Rajeshwari Chandrasekar. She's an old friend of the center. We have done many collaborations. She's the chief of field office, UNICEF Maharashtra. She has been with UNICEF for more than 20 years, 25 years, serving both in India and abroad. Her background is in policy, planning, monitoring, and evaluation. And she has a master's in economics, has published a number of papers in this area. And then she has an amazing, incredible experience on the ground level, and she will share those experiences with us today. And we have, we're so happy to have Dr. Sanjay Kapoor. He's a managing director of John Snow India. He's a public health specialist with more than a quarter century of professional experience on reproductive and child health and infectious diseases. He's a member of several policy and technical committees of the Government of India, and he often is invited to speak at different international and national meetings and forums or fora. Is a recipient of a number of awards for the work he has done. He has been leading JSI since 2014, bringing together various stakeholders in advancing the cause of immunization and a number of other public health causes. So thank you all so much for joining us. What we will do today, we will start with you. For the audience who are here today, the way the program flow will work is I will have the panelists make very brief, a 1 to 2 minute opening remarks, followed by questions from me to the panelists. And at some point, we will open it up for the audience. We'll discuss maybe roughly for about half an hour, 30 minutes, after which we will open it up for audience questions. So if you have questions, please post them in the Q&A box that is on the bar tab below the screen in most cases. Dr. Ramya Pinamaneni here is monitoring the Q&A. She will send me the questions and I can ask the panelists. So those are the housekeeping duties. So let's start with, this, by the by, I've been reminded, which is good. I have a great team. I think I'm so grateful to the team. This webinar is also sponsored by Project Sanchar, which is funded by Bill and Melinda Gates Foundation at Harvard Chan, promoting really translation of evidence base. It's research and science communication, to be translated for both for journalists and decision makers. They are the co-sponsors of this webinar, and so you will see my team posting information on Harvard Chan Center as well as on Project Sanchar. So let's start with you, Ms. Gupta. Thank you for joining us. So you have the enviable position of knowing both the country story in India as well as the global story, but not everybody may be familiar with Gavi. And so tell us a little bit about, from your perspective, in the next couple of minutes, what are the joint priorities? What do you see as a reason for the success and the importance of it?
So thank you, Professor Viswanath and the team. So to your question, and to something really that you said in your opening remarks, that vaccines save lives, right? And therefore have an exponential return. And yet the unfortunate thing is that in 2000, poor countries did not have access to life-saving vaccines. Millions of children were dying in poor countries because of diseases which could be very easily prevented by the use of vaccines. And those vaccines were available in rich countries, but they were just too expensive. And that was also the time when the routine or the coverage of certain basic vaccines in low and middle income countries had started to stagnate. So that is the backdrop against which Gavi was set up in 2000 at the turn of the millennium as a very bold experiment. It is a public-private partnership. It brings together diverse stakeholders, which include, of course, the UN agencies, WHO, UNICEF, World Bank, but also private foundations like the Gates Foundation and several other private sector entities. And then, of course, the sovereign donors, the implementing countries, and most importantly, the vaccine manufacturing industry, in addition to the civil society and academia and researchers. And these, as you know, are strange bedfellows, but the alliance model actually pulled them together, and they are a part of the governance of the alliance, and therefore are all partners in progress. So what happened as a result of Gavi's establishment was that access to new life-saving vaccines started to become possible in 73 lowest income countries that Gavi began to support. Today, more than 300 vaccine programs have been introduced in these countries, and the vaccine preventable child deaths have actually fallen by a stupendous 70%. I think what is phenomenal is that the coverage of key Gavi-funded vaccines, which is HIP, Rota, and pneumococcal, that is higher now in Gavi-supported countries than the rest of the world. We have also seen tremendous progress in coverage of basic vaccines. For example, when Gavi was set up in 2000, the coverage was 60%. And now in Gavi countries alone, pre-pandemic in 2019, it had touched 81%. But more importantly, the number of under-immunized children who were not receiving the third dose of DTP actually was halved during these 20 years. However, that said, I think there are still challenges which abound. And the biggest challenge is of persisting inequities in immunization. So what actually we did at Gavi, and I led that work, was to really dissect the 15 million children who were not getting the third dose of DTP in Gavi-supported countries. Globally, that number was 19 million in 2019. And what we discovered was that 2/3 of these children actually were zero dose, that they were not receiving even the first dose of DTP. And then our analysis revealed that 2/3 of these zero dose children actually live in extreme poverty in households which subsist on less than $1.90 a day. Also, that they represent households which are suffering from multiple deprivations. For example, mothers in these households have a much higher likelihood of not receiving antenatal care, skilled birth attendance. Most often, these households do not have access to water, sanitation, hygiene, nutrition. Children are not in school. But the most important thing that I want to really leave with the audience here is that though 1 in 8 children was zero dose in 2019, so about 11-12% children were zero dose, they accounted for a whooping 50% vaccine preventable child deaths. So I think one thing is loud and clear, that we really want to bend the curve on child mortality, which has started to stagnate, frankly, for the last couple of years. Then we really need to bring a laser focus on these zero dose children. And the final comment that I would make is that the pandemic, the last 2 years of the pandemic, have actually given a serious setback to immunization globally. Immunization rates have plummeted for the first time, so steeply. And there is an increase in the number of zero-dose children. So the number of zero-dose children has increased globally from about 14 million now to 18 million. So there's about a 37% increase, which really means that the risk of disease outbreaks, disruptive disease outbreaks, is all-time high. There is also a risk of spike in child death. So this is really the moment for immunization to pivot. And I'm really looking forward to this very timely discussion today. Thank you.
Great. Thank you, Ms. Gupta. I think that was a wonderful, you really painted a broad brush of both the origins as well as the challenges we are facing. So just to the audience, again, if you have questions, please feel free to post them in the Q&A box, and we are monitoring the questions, and I'll be able to open up and ask the panelists the questions you have. And I'm glad, Ms. Gupta, you started by centering equity and justice, right? I'm so glad you began that. And so I want to next go to Ms. Rajeshwari, who can offer the issues of equity and information on it from a ground level. Given the work you are doing, Rajeshwari. So go ahead. I think you have one slide, right? So
thank you so much. I wanted to actually, while echoing what Mrs. Gupta was just saying, is to say that yes, immunization is indeed a big investment globally. Are you able to hear me?
Yes, we are able to hear you. Yes, please go ahead.
Big investment globally. But, when you look at progress within the country, that's where now, as she rightly pointed out, you start seeing up. So there has been uneven progress within states. If I were to just take you through are you able to see my screen? I want to just take you to when I say about unevenness in the spread within the states and of course across the states. I want to take the example from Maharashtra itself, where I work, and we have 3 topographies. And I start with Rani, who is an A&M in Nandurbar district, which is a tribal district with over 70% population tribal in the state, and probably the highest tribal district, plus an aspirational district for Government of India. She is on her way to attend a VHND. And where does she go? She goes to a far-flung habitation, which has 50 people, inhabitants, but only 2 children to be immunized. But yet she goes despite rain or despite sunshine, because she has to trek that huge far-flung habitation to reach those 2 children to be immunized. I now go to urban slums, another completely different scenario. We have Rukshana, the mother of a 6-month-old baby, and she lives, of course, in Dharavi slums of Mumbai, right here where I also live in Mumbai. She works as a domestic help. She is blissfully unaware of the fact that her child is in need of immunization. She does not know where it happened. She does not know why it should happen. This is as another challenge which will also show, apart from the macro data, where we have the gaps in the last mile. My third example is of COVID-19 vaccination, something that even Mrs. Gupta alluded to. And I'm taking the example of Kolhapur in a municipal corporation in Maharashtra, which had a large number of COVID cases, and not peculiar to Kolhapur, but yes, I did stumble across it when I visited Kolhapur. A lot of areas where, according to our Google Maps, it showed that there were a row of houses whose adults had not been immunized. And when we went into further why ask who were those adults, they were actually women, and they were in the business of selling their bodies at night. So it was a red light area. Now this had an issue of stigma of those people going to the center for immunization, and an issue of attitude of the service providers to go and provide them at their doorstep. Of course, it got eliminated when I spoke to the municipal commissioner and she was made aware. And of course, then the cases were addressed. But this is a typical scenario I would see within one state, where we have the topography of tribal, urban, and the issues of resistance to COVID-19 vaccination, which might actually pull down what is at a state a very good average, whether it is for routine immunization, whether it is for COVID specific. I think all our policies and strategies and design must look at disaggregation at the level where it matters more. So this was what I was trying to say when I said that while on the one hand, immunization contributes to 12 of the 17 SDG goals, and therefore, like Mrs. Gupta rightly said, the investment to outcome ratio is very good. But in disaggregating to the geographical realities of what we face, our design must recognize these disparities as well. Thank you.
Great. Thank you so much, Rajeshwari. So you painted, really, there are two things to observe here. I mean, maybe I'm imagining a little, reading a bit too much into it, but that nice gradient you had from tribal to urban to the COVID, the other challenges. And then we have this wonderful picture, what's happening globally, the planning, the work that's being done, the challenges that we are facing at the ground level. So Dr. Kapoor, help us out here. So what do we do? You're up there in Delhi coordinating and helping and bringing together everyone and planning. So what are you thinking? So.
Well, from the India perspective, I think in the last decade or so, India has made significant progress in terms of overall coverage, in terms of adding new vaccines, in terms of VPD, vaccine preventable disease surveillance, in terms of developing new digital platforms for reaching out to different people, and COVID is one example. I think she's right in saying that COVID-19 vaccine did slow down the progress, but I think with the government of India in the lead, India is continuing to make significant progress in the area of immunization, supported by a large manufacturing facility also. But I agree with the previous two speakers that there are sort of challenges on the ground in terms of inequity, in terms of also quality, because not all vaccination sessions are of that quality which they are supposed to be. And there are other challenges which I can talk as we go along. But I do agree that, while India is making progress, has made a lot of progress in the last decade or so, but I think we have still a way to go in terms of reaching our goal. So that's what my small contribution is. But I would, as we go along, I would like to highlight some of the specific achievements and also some of the specific challenges which India is probably facing at this point of time. Over.
Great. Thank you, Dr. Kapoor. We'll certainly talk about challenges shortly. To the audience again, you have begun doing it already. Please feel free to post the questions in the Q&A box, and we are monitoring them, and we'll be happy to pick them up shortly after I ask the panelists a few other questions. So, Ms. Gupta, one of the issues that came up as I kept hearing you, and you are following your work. I've been following your work, amazing work, for a while. So you have 60 countries. It's a kind of, 60 different governments, 60 different policies. So you're coordinating at the top. And you just heard Ms. Rajeshwari telling that stories. In fact, not one story, right? It's very different story from place to place. So how do you manage that broad global level policy and planning with this kind of a variation that goes through individual countries? How do you negotiate, navigate, provide the kind of a technical capacity you need to do?
Yeah, so excellent question. As I said, when Gavi started out in 2000, we started to support 73 countries, right? But Gavi also has sustainability at the heart of its model. So country ownership, and therefore we, as country income goes up, there is a policy that we have that we progressively work with the country governments to increase their domestic financing for immunization and begin to then finally assume full responsibility. And that is why 16 countries have now successfully transitioned out of Gavi support. And you refer to a certain number, right? So we now have 57 countries that we actively support. But of course, we maintain a certain level of support to countries that have already transitioned out of Gavi support, so that their coverage, and particularly equity in immunization coverage, does not start to suddenly suffer or receive a setback. Now that said, so the first 15 years of Gavi, till 2015, the focus was on introduction of new vaccines, because as I said, there was a huge gap and in terms of access to new vaccines. So there was really primarily a challenge of inequity between countries, right? We know that pneumonia and diarrhea are the biggest killers of children, and yet low and middle income countries did not have access to these two vaccines. So I think the first 15 years, therefore, Gavi just focused on making sure that we shape the vaccine markets, we secure highly affordable prices for these vaccines, and then we make sure that we support countries in not just accessing these vaccines, but also delivering them to the population. And that's why we saw the progress that I earlier mentioned. But when I joined Gavi in 2014, actually we embarked on a new strategy that brought about a new shift, which was a very country-centric shift, and based on my experience in India, where I had started to really talk about high burden districts, because some of the people who are here, including Sanjay, would know that I'd started to dig deeper into data and say, look, the whole UP doesn't have a problem, or because we were in the past, even in India, very focused on certain states, which we used to call Bimaru states, with the health lag. But what I did was to say, look, you have to disaggregate data, because even UP's macro data hides, provincial disparities, and then we district level disparities, and then we started to highlight. I remember how in Stravasti, the immunization coverage was less than 10% versus Kanpur, which was as good as the national average. So I think that whole focus then, and that experience, I actually brought to Gavi, and then at Gavi we started to talk more and more about heterogeneity, in among countries, as you rightly pointed out, and then I started to say these 70 plus countries are not a homogeneous lot, that they are very different, and we really therefore need to make our policies and support much more flexible and contextualized. And then the next thing that we did was to actually then work with countries to underscore the importance of having a subnational focus. Because as I said, and that was really based on India experience. So for example, when I went to Chad and had all these high level meetings with the president and others, we were at pains to highlight how their nomadic populations had immunization coverage as low as 2%. And that's the time that we sat down with Chad government to actually tailor tailor a strategy that co-delivers livestock vaccination with child vaccination. And that actually pushed up vaccination rates in Chad, because this new approach was targeting very precisely subnational disparities and encouraging much more tailored community-based approaches. And believe me, if you look at data from 2015 onwards, when I first visited Chad and we started to really get into the nitty-gritty of subnational variations, today Chad has improved its coverage by 17 percentage points. And despite the pandemic, it hasn't looked back. You know, it was always the most challenging country in Gavi portfolio with less than 50% coverage, but now it is 58%. So really it's a country where people didn't see any hope. So now what we are really doing is to make sure that we continue to work with countries to really highlight the importance of dissecting and triangulating data to exactly understand what Rajeshwari was highlighting. And that is why the zero dose concept is such an important one. And Rajeshwari highlighted the Indian context. But let me add that globally, when we look at these zero dose children and where they are, what we found was that 50% of the zero dose children actually are found in urban slums, you know, where of course the number of, the people who are migrating from villages and do not have access to essential services is constantly increasing. Remote rural areas where service delivery still continues to be a challenge, and then conflict zones, right? But we also found that 50% of zero dose children are just dispersed. They are in non-specific settings. And that's where, you know, the point that Rajeshwari was making, you could have red light areas, you could have stigmatized populations. We also found, for example, in Afghanistan, you know, there are ethnic minorities, right, that suffer from a variety of barriers. Laos, you know, I went to Laos and we found that ex-Hmong is an ethnic minority, you know, that really suffers from access barriers because their language is prohibited, you know, for use by the national legislation. And how do you communicate with these communities? You know, if you so increasingly, the point that I'm trying to make is that while we have a policy framework, we have introduced so much of flexibility and an appreciation and acknowledgement for heterogeneity among countries, but also within countries, the subnational context, and that is where we are increasingly leaning in to support countries to get to these zero dose children and community.
Interesting. We thought we had Dr. Babu for a second there, but we seem to have lost him. My team, we are having some technical problems. My team is working with him, trying to get him on board. But we'll continue with the conversation while we're waiting for him. You know, a mentor, a statistics mentor of mine used to say, we pay a lot more attention to averages, but variance is as important as averages. And you just offered that insight that it's just not between country, but within country variance that is so critical. I just want to, I'm curious, there are two issues that you raised, Ms. Gupta. I think I want to come back to both of them. The first one, so Rajeshwari, what do we do at the ground level? How do you take into account this different variation, but cultural, socioeconomic, geographic? Can you tell us an example or two of how you have managed to do that
yes,
and successfully? So.
See, one of the things is a very basic thing from the supply side. So there's a demand side and there's a supply side. I think from the supply side, we will have to re-look at the micro planning. We are very good at doing conventional micro planning and convenient micro planning, if I may say so, because there are areas that we very well know where the household is and not is. But there is something where you have to go beyond the boundaries of the comfortable micro planning. And I think these are the areas where probably you will not find, you might find a house locked, you might find population not there, but going back and back again to them. And I think this is where I see the role of development agencies like WHO and UNICEF supporting the government in doing this kind of thing. The other one is, given the obstacles of, from the demand side, let's say, of stigma, discrimination, lack of knowledge, and these different topographies, it becomes important to also support the government in establishing partnerships which are non-conventional in nature, which means you will have to look at faith-based organizations. You see, one good thing that has happened with the COVID pandemic is the trust in the frontline functionaries has increased tremendously. So, but they only have that much of reach, and they can only do that much in a given day. But you have these network of faith-based organizations and other youth volunteers, media persons, and especially in tribal areas, you have youth volunteers who are meant for doing, even passing on any other messaging with the non-traditional methods of communication. I think tapping them into this campaign kind of thing. And what I did specifically in the urban slums that Mrs. Gupta referred to, we had something called Chalta Bolta, which means, it just means a person uses a mic and an audio system, walks along the slum areas and tells them, you know what, and it's based on a narrative, you know, I took the vaccine, this happened to me, now I'm free, I will not get the COVID. When you talk positive stories, the household people come out and they start understanding, oh, if it has happened to this person, it can also happen to me. So I think these are some of the very good examples that we have learned, done, experienced, and therefore have proven to be successful. Again, when we talk of urban slums specifically, because they are working on a huge urban program. If I just look at another ward called M East in Bombay, which is, you know, one of the biggest and the most vulnerable slum, it is wrong to say, and of course it has a huge Muslim population, but it is wrong to say that it is only minorities who say no. Even within the slums, there are many other communities and other ethnic groups who would say no to immunization, be it for the woman or be it for the child. And I refer to one community called Pardi, whose job profile is to go from 8 in the morning to 8 in the night. So they are not there when the frontline workers are coming to give, whether it's through a camp mode or through a session mode, they are not around. And when they, even if the health functionaries were to change their timing, the Pardi community will not agree just because of one such interaction. So I think is to recognize those, differentials within a given space and look at how best to reach them through known faces in the community, which I think is the answer to address the demand side. So there is a supply side of this, cold chain, the vaccines, but there's also the demand side. And to repose the trust in the health worker, which is already, I think, now at an all-time high, thanks to the pandemic, we have to just keep that going.
Thank you. I think we will, the supply side of India success requires a whole webinar by itself. And we certainly, I think you're correct, we should talk about it at some point. And we are focusing on the demand side. When I chaired the Vaccine Confidence Working Group for the National Vaccine Advisory Committee, so one of the issues, we figured out as we began having public testimonies from experts is an issue of balancing, the local versus national, and what is culturally specific, but also trying to understand, how do we share those lessons learned, from different groups, so that we are not reinventing the wheel all the time. So, Dr. Kapur, what do you think? You are sitting at that intersection of doing these things. What can we learn from these stories? From different places at the global level, we have these plans. At the local level, we have these heterogeneity and stories. How do we handle that?
So, I think correctly said before, I think we need to do a micro targeting of different vulnerable populations. I think one size will not fit all, and what may work in one state or one district would probably not work in the other one, because the local ecosystem, the local influencing, the local bottlenecks or the barriers may be different. What we have learned also in COVID vaccination when we supported the government is that, let's say in the Northeast, the situation is very different. their barriers and their mindset is very different, and therefore to reach out to them we need to do a micro targeting of the strategies. As compared to Maharashtra, from where Rajeshwari ma'am comes, the situation there is very, very different, and therefore it is very critical that we actually document in a deep manner the things which have worked in the particular vulnerable communities and try to share them through national forums, through public private partnerships, or through other regional forums. Things which have worked and also things which have not worked are equally important. I think that emphasis on sharing good lessons, positive case studies, positive deviant stories is very critical, and as much as we can do, it would help convince people to take vaccination for children as well as for mothers. What we have done to help the government is that we have identified specific populations, for example tribals, for example religion minorities, for example migrants, for example riverine areas, where we have actually gone with specific teams, sat with the people, talked to the local influencers, identified the local opportunities, identified the local barriers, and come out with solutions, or at least documented possible solutions which others may probably value and try to use them. May not be in a very sort of exact photocopying manner, but also they can adapt to their local situations. So it is very critical that there is a lot of documentation of that. I'm not sure we have done enough, and I think that's a work in progress in India of actually documenting very positive case studies in different vulnerable populations, urban areas, slums like Dr. Anuradha Gupta madam mentioned. Urban slums have their own ecosystem and their own problems, both demand and supply. One last point I want to mention is about the demand. I think we need to give a lot more importance to demand generation through specific community engagement strategies. A lot of the action till now has been a lot of the push factor where supply, it's been a supply driven program. But if we really want to identify zero dose children from back of beyond places where the health system does not reach, where people are at the margins, they don't even know about it, they have specific inhibitions to give vaccinations to their children. I think we need to invest a lot on demand generation through specific community engagement strategies. Because in India, for example, why should we have zero dose children when we have 85 or 90% institutional deliveries? There must be something wrong, because they have come in contact with the system, health system, yet their children are not getting immunized. We need to sort of identify those reasons, that where is that bottleneck, where is that failure, and then try to identify those specific solutions, because one size will not fit all, particularly for India. India is a huge country. UP, for example, is the 6th largest country in the world. Even for one of UP, we cannot have one single strategy. So we need to really dissect, document, and then share.
Great. Thank you. That was wonderful. So to the audience, we will be going to your questions. I'm being fed the questions from my team now. So please post the questions in Q&A. Our team is monitoring them, and they'll send me the questions to be posted. And just for those of you who have joined late, unfortunately, Dr. Ashok Babu has been facing some technical problems, so he has not been able to join us so far. We thought we had him for a second there, but the technical issues remain and continue. I want to go to the audience question next, but I just want to note one point. I don't know whether we'll have time to come back or not. So as somebody who focuses on communications, a student of communication who does research and write in this area, certainly this kind of a segmentation and developing messages and platforms that are culturally, geographically, and socioeconomically proximal to people is very critical. But there is a tension here. The tension is if we make it, how can we share the lessons learned? And if we claim that everything is too specific, then we are not sharing the lessons learned. We won't learn from others, right? So one example is a faith-based leaders. Of course, you can use imams in one country where they're valued. You can use priests in another country, right? So there is that possibility that we can still learn from each other, and not reinvent the wheel, as I said. So let me go to the audience question. So there is a question which says, in terms of vaccine safety and disease surveillance, what are the key areas we have to focus on? Apart from capacity building of ASHAs and grassroots healthcare providers in the low and middle income countries, what else should we be doing? So maybe we can start with you, Rajeshwari, because you are at that regional, local level, and then we can go to the global issues.
Yes, actually, I had raised my hand a little earlier after Sanjay.
Oh, sorry.
To tell you that I had, I got provoked by what he said to look at, to shift from this issue of coverage to equity and resilience. We should not just look at, if I just take 2 districts from Maharashtra. We have Pune, which you are aware of. It's a very well-developed district on the western coast in terms of all indicators. And you have that Nandurbar, which I mentioned in the very beginning. If both districts, for example, show 70% or 75% immunization coverage, it does not mean they're both equal, because the resilience of the health system in Pune any day is stronger than the resilience of the health system in Nandurbar. So anytime if another pandemic or something else was to come, that 70 in Nandurbar will slip down to 20, but Pune might still remain at 70. So I think we should shift our focus from the principle of coverage to the principle of resilience, which is to build health systems so that they're able to take this forward no matter what other pandemic. But coming to your current question, I think, there is a lot of role that development organizations can play to advocate with the communities, because the government of India in the Ministry of Health has asked that the ASHAs and the ANMs provide those 4 key messages to the mothers, which is what vaccine was given when the mother brought her child and what disease does it prevent. Number 2, when and where to come for the next dose, next visit. Number 3, what could be the adverse events after that vaccination, if at all, for that child? And number 4, to keep the immunization card safe with her, so that should she migrate for work, wherever she goes, she will get the next dose for her child. Now, this is very well designed by Ministry of Health, but I think down the line, there is a weakening of that messaging. So many times the mother goes to a VHND, her daughter or her son gets a shot. She does not even know that she has to ask these questions. I think this is where development agencies have a very significant role to play in letting the ANM and ASHA know that when a woman comes, here are the 4 key messages, and in which dialect you say, how you do it is of course very localized, that adaptation. But I think there is a very big opportunity there to pass on the message to that mother. Actually, it is about entitlement education, if I were to say. That mother needs to know what she's coming there for, when should she come again. Right now, I don't think that information is there, because there are so many children to be vaccinated that I don't think there's time for each interaction for that exchange to happen. I think this is where the role of the agencies, be they faith-based, youth-led, or UNICEF as well, and WHO, especially UNICEF, because WHO is more on the supply side. I think we have a big role to play in passing down that information in a way that is simple and easy to register for that parent who brings the child. So I think here I find there's a lot of scope for improving the communication to that last mile, because the biggest challenge in the immunization game is not at the state, not at the district, not at the block, not even at the village, but it is at that household who's in the last mile. Whether it's a tribal, it's a nomadic, like Mrs. Gupta said, I think that is where the problem is. Over.
Excellent, thank you. In fact, I was going to come to you, Ms. Gupta, now, because exactly this issue of how do we do this? You actually alluded to this point in your opening remarks about multiple factors influencing this. So you also spoke to the system strengthening. From your perspective, what do you say? You already had your hand up, anyways.
So just a couple of things. One is that we all constantly talk about health systems, right? Health system strengthening and resilience. I just want to make a bit of a discordant sort of comment here. And that is that we have to understand that people who suffer from the most acute inequities actually are not in a position to benefit some resilient or strong health systems, right? So I really think that the focus has to move from health systems to service delivery, right? Which is bespoke service delivery for these populations. Why do I say that? For example, there are children, right, who are living under the shadow of the gun, right? Those areas are militancy affected, conflict affected, in the control of rebels. So you really have to negotiate, peacetime, during which immunization services and other essential services can be delivered to children. So you're not talking about health systems here. You're talking about service delivery, but service delivery which is not erratic or sporadic, which is regular and reliable. So and there's a lot of powerful evidence now coming out saying that the most vulnerable and marginalized populations would always find it very difficult to access fixed health facilities, right? And therefore, community-based service delivery models will have to be thought about and put in place. So I just wanted to bring in that nuance. Also in urban slums, where a lot of people are actually squatters, and the government is in a denial mode. They don't want to even admit their existence because they are scared that they would be legitimized, right? So therefore, they are deliberately denied services. And of course, then they're so overcrowded that there's no space there to put up a health facility, right? So the point is you need to then probably think about mobile service delivery approaches for these populations. So I just wanted to make that point that sometimes people think that health systems is about brick and mortar. But fortunately, immunization is not a service that is dependent on brick and mortar. It can actually be delivered in outreach settings very easily, right, under a tree, right, in an open space. And I think that is what makes it much easier to deliver immunization, say, compared to skilled birth attendants, because you really need a better equipped health facility for skilled birth attendants or somebody or skilled birth attendant to go to the home of the mother. So I think that's more complicated compared to immunization. So just one thing. The second thing I would want to make is the point I want to make is about gender. I think gender considerations have not been paid due attention in the design of immunization program. Based on my own experience, what I've seen is that the disproportionate burden of bringing your children for immunization actually rests on the shoulders of mothers in most settings, right? And now we haven't thought about, designing our services around the convenience of the mother. And therefore, like Rajeshwari hinted, I've seen many cases where in urban slums, poor women are out working during the daytime. And, they are not in a position to forego their daily wages, right, to attend an immunization session that happens at 12 o'clock or 11 o'clock in the daytime. And therefore, what we found, for example, in Dakar, in Senegal, was that when the time of the immunization session was changed to late evening, or, weekend immunization sessions were organized, it actually made it so much more convenient for mothers to bring their children. So I think the location of the immunization, paying attention to these simple things, it's low-hanging fruit. What is the location of the immunization services? What is the timing of the immunization session? And then, of course, stockouts. We don't talk about, we talk about all this supply chain, but we know that at the peripheral facilities, a lot of times there are stockouts. So when a mother comes with her child, she has to go back disappointed because there are just too many stockouts, right? So I think these are some of the things that actually deserve more attention. And then, of course, on the supply side, and then, of course, the provider attitude. I think somebody alluded to this. I think that's a very important consideration in spurring demand, because when certain subpopulations are stigmatized, or health workers are not courteous, right, or they are not ready to devote enough time in counseling the mother about adverse events following immunization, clearly mothers are disappointed and demand goes down. So to me, demand and supply are highly interconnected. And we know that maternal education always has an impact on immunization rates. But we also know that we cannot, as immunization community, you can't go and start to educate mothers or, send them to schools. But what we can definitely do is to design our communication strategies, in order to really make sure that even mothers, though uneducated or illiterate can still understand the benefits of immunization. Just on partnerships, I want to make one point that I completely agree that partnerships have to be much broader, and we really have to create more space for local partners, including faith-based organizations. And I think from Gavi, that is what we are doing. Increasingly, we are saying, look, this whole globally driven model where, the global partners, go into a parachute. So what is the current model of technical assistance? I really feel we ought to decolonize the current model of technical assistance, because the current model of technical assistance is predicated on two things. One is you parachute global international consultants into countries, and they don't understand the country context or the cultural sensitivity. So often the solutions they design are quite misplaced. Or second is you poach the most talented people from the ministries, right? So all our talent, whether it's Rajeshwari or it is Sanjay Kapoor or it is Anuradha Gupta, they just come and poach, right? So I really think that, therefore, coming to the point that was raised, how do we create a community of practice where we create more opportunities for peer-to-peer engagement so that actually people are able to share good practices, examples of positive deviance, and they inspire each other and they learn from each other, and then they know. So I think that to me is something to really be pursued.
Wonderful. Thank you so much for the detailed answer. So we are actually out of time. But Dr. Kapur, maybe 30 seconds, you want to make a point, and then we'll stop right after that, maybe 30 seconds.
Yeah, just one point I want to mention, and I think it's a culmination of what all we have discussed, is that we should keep community at the center of any plan.
Yeah.
I think what we probably have not done enough is that we have designed programs in the halls of in air conditioned rooms without keeping the varied communities at the center of the plan, because a community's needs are different and therefore the plans have to be different. On gender, I think one example which we have seen in India is so-called pink clinics, because in specific religious sub-communities, we saw that women were not coming to the vaccination clinics because there were men there. So there was an example that they set up pink clinics, which were women-only clinics, and there was a significant increase in sort of women bringing their children to the clinic.
Right.
So those local solutions have to be thought about with the community at the center of everything. That was my 30-second pitch.
Thank you. Wonderful. I think we can do this webinar for 2 more hours and we still won't be done with it. Particularly, there's an area I thought issues of discrimination, gender, and migration is very critical, and some of you are working on it. So hopefully someday we'll probe a little bit more into that. So I want to thank each of the panelists. Ms. Gupta, Ms. Chandrasekar, Dr. Kapur, thank you so much. We really learned a lot from this. You raised so many important issues, and I wish we could probe each of them. But thank you for joining us. This is a starting point of a conversation, not the end. So hopefully we'll continue this dialogue. I also want to thank the audience for participating in this webinar. The recording will be available. My team is posting all of our social media hashtags and information, so please log on. This recording will be made available and we'll make the announcements. And also, I will be remiss if I don't thank my team. They are so wonderful. They work so hard behind the scenes to make these things possible. So thanks to my team. Again, thank you, everyone, and thanks to the panelists. We'll be in touch with you. So grateful for your participation here. Thank you.
Thank
Bye.
you. Thank you, everyone.
Thank you so much.
Bye.